inviting me. So I'm going to talk about COVID and the brain, but I'm not going to give you a talk like this, full of cytokines and proteins and mechanisms. One, because I don't think I'm the right person to talk about that. And two, because I want to try and talk about something broader, something about how the story of COVID and the brain is actually really part of a bigger story. So a couple of housekeeping for me to say up front, which is that this isn't a finished story. I don't know the answer, and I don't believe anyone knows the finished story of what's going on here. The brain and mind issue, I think, is a really important one to say up front, that I'm talking about COVID and the brain, but the brain and the mind live in the same place, and I don't really think it's possible to talk about one without talking about the other. So we're going to talk about a bit of both. I'm a neurologist, not a psychiatrist. What does that even mean? What is the difference between the two? There certainly isn't a clear-cut distinction. Also, I'm speaking in very broad terms here. I'm speaking about patients that I've seen in broad terms, and I'm speaking about research that I've done and research that I've seen in broad terms. There's going to be individuals out there who've had different experiences to what I describe here. And that's okay, because I'm not talking about specific individual experiences. I'm speaking in broad terms. And I've not given you a talk full of loads of scientific references because it's a bit much for lunchtime, but happy to discuss anything further if anyone wants to go into the data of what it is I've spoken about. So here's a rough sketch of what I'm going to go through. I think when you think about COVID in the brain, it's helpful to think about the acute brain problems that happen during a COVID infection and shortly afterwards, and the chronic problems, the ones that take a long time, months or years to develop and persist. And in those acute problems, we're going to talk about stroke, we're going to talk about inflammation of the brain and the nervous system, and we're going to talk about mental health problems. And in those chronic problems, we're going to talk about dementia and long COVID. But what I also want to say is that this isn't an exhaustive list. And obviously, I'm concentrating on the brain, given who I'm talking to. I'm not talking about the complications that affect the peripheral nervous system. But what I really want to emphasize is that, are these all different ends of a multifocal pathology? Are these all representing different mechanisms which actually can occur together? I think that might be the case. So stroke, we know what stroke is. It's a brain injury due to loss of blood supply. It can be ischemic, where blood supply is blocked, usually by a clot. That clot can form in a blood vessel in the brain, or it can shoot off from somewhere else, usually the heart, or it can happen because of a tear in a blood vessel, which causes a clot. Or it can be a hemorrhage, a bleed, usually because of a weakness in a blood vessel. Now, all of that, what I've said, happened before COVID. Stroke was obviously a very common disease, but we know that the risk of all of those things is increased during and after COVID infection. And that is independent of the other risk factors for stroke, which we know well: vascular risk factors, age, diabetes, blood pressure, those sorts of things. So COVID is independent of those risk factors, but it's also additive, right? So we've seen plenty of people who've had strokes associated with COVID who were young, fit, and healthy. But we've also seen a massive number of people who've had strokes associated with COVID who have lots of other risk factors for stroke as well, and COVID has added into those risks. Now, what some of our research has found is that the strokes that occur in association with COVID do tend to be a particular sort on average. They tend to be quite severe. They tend to be quite disabling. And sadly, people who have them tend to be more likely to die than those who have strokes not associated with COVID. They tend to involve multiple occlusions of large vessels. So that means maybe the middle cerebral artery and the anterior cerebral artery, maybe the carotid artery, maybe both sides. And they tend to be associated with extracranial clots. So not just a blood clot in the brain's blood vessels, but associated with that, a blood clot somewhere outside the brain, like in the liver or the kidney or the lungs, suggesting that they're occurring as part of a more global problem of blood clotting, right? And the risk of stroke seems to be highest in the first week of COVID, but does seem to persist much longer, maybe up to a year even. And it's not clearly linked to how severe the acute COVID illness is. So certainly I've seen some people who have had a relatively mild COVID infection and gone on to have a stroke. But it's important to say that though the risk is independent, it is additive with other risk factors. And interestingly, in terms of treatment, we know that a lot of the COVID treatments, like dexamethasone, an anti-inflammatory steroid drug, and remdesivir, an antiviral drug, do reduce the risk of then going on and having a stroke. Also, one other interesting thing is that thrombectomy, passing a wire up into a blood vessel and removing the clot, is now more and more becoming a standard of care treatment for stroke. And that's more difficult in COVID-associated stroke. It's more difficult to pull the blood clot out. And that may be because the blood vessels are also inflamed. That could be part of the problem, and that those inflamed blood vessels make it more difficult to pull the clot out. So here are some scan pictures from a paper that we published. Up here in panel A is someone who had an internal carotid artery dissection. This is an angiogram showing the internal carotid artery here, and where it abruptly stops there's been a tear in the blood vessel. That's blocked blood flow and caused clotting to happen. And then on this MRI scan, you can see a huge area of acute infarction, damage to the brain because of loss of blood supply, which is swollen. That's what the brain does when it's injured. And here you're seeing a different kind of pattern. You're seeing different small strokes in different parts of the brain. And here you're seeing lacuna strokes, very small strokes, spread all across the brain, suggesting more that there might be a problem with inflammation of the small blood vessels. And on this scan, what you're seeing is someone who's got an inflamed blood vessel there, the middle cerebral artery, which was actually treated with anti-inflammatory treatment and caused that inflammation to dampen down. So quite different mechanisms of stroke. And there's also other mechanisms to think of that we don't see here. So I knew of a lot of people during COVID who, because they were unwell, stopped taking medication that they might have been on to prevent stroke, because they were worried about interactions, because they were so unwell they couldn't take medication. And then that was associated with them having a stroke. So that's a completely different mechanism, more of a behavioral mechanism, but something that could also link COVID to stroke. And that kind of brings me to a more broad point, which is, well, I've just been telling you about how COVID's linked with stroke. Okay, so you would have thought that there would have been a massive increase in strokes during the pandemic. Well, there wasn't a massive increase in stroke admissions. If you look at what was happening to stroke admissions to the NHS before the pandemic, it was increasing year on year. And in the year of the pandemic's peak, there was a massive decrease. So what that tells you is that biology is not the only right level to look at the impact of COVID on the brain. I showed you lots of biological stuff showing how COVID might inflame the blood vessels, cause blood clotting, so on. But I also told you about psychological impacts of COVID, where people might change their behavior, not take their medication. That might be associated with stroke. And there's obviously also societal impacts. There was a lockdown, there was a pandemic. People, were afraid to leave their home and therefore might not have presented to hospital. So to understand this, the population level data, it's not enough to only understand this. We have to also think about biology, psychology, and sociology all together. And I think that's an important theme going forwards. So now let's talk about inflammation. Now, there have been loads of syndromes recognized. We've published, and many other people have published, on conditions where the brain becomes inflamed, usually during or shortly after COVID infection. And there's lots of different names given to these syndromes: leukoencephalopathy, inflammation of the white matter, PRES, posterior reversible encephalopathy syndrome, basically means inflammation of the back parts of the brain, especially the blood vessels, and lots of antibodies that have been associated with this condition. This particular one that I've listed here, MOG, myelin oligodendrocyte glycoprotein, is a protein found in the brain that when your body makes an immune response to fight a COVID infection, it can cross-react and accidentally make antibodies that also target this protein. And we've known that for a long time with loads of other infections before COVID and since. But we seem to have seen a number of these cases during COVID. This antibody in particular, MOG, we've seen a number of cases in Southampton, and there have been many reported worldwide. Here's a scan of someone who had that condition where we saw a great deal of inflammation and swelling in the brain associated with COVID infection and this MOG antibody. And this is where they've been given a contrast dye injection. You can see that the blood vessels have become leaky. That's why the dye is leaking in here. And after steroid treatment, that resolved quite dramatically. So I'm not going to say lots more here, other than to say we knew that this existed before COVID came along. It's no surprise that we've seen a number of these conditions come up. Does COVID in particular cause it more than other infections? Now that's an interesting question. There hasn't been any clear evidence to answer that yet. There's a good reason to think that it might do, because the receptor that the SARS-CoV-2 virus binds to is the angiotensin converting enzyme, which is widely expressed on the brain's blood vessels. So there's a good reason to think that COVID might have a particular reason to go and cause inflammation of the cerebral blood vessels. Now, then the other thing that people have spoken about a lot is infection. Does COVID actually infect the brain? Now, I think we have to be quite specific about the terms here. So when we say infection, do we mean, does it get into the brain? Because lots of viruses and pathogens get into the brain, but don't actually cause any problems. Does it actually infect nerve cells? Can it grow within nerve cells? That's what tropism means. And does it actually cause a problem? Because there are plenty of viruses, such as Epstein-Barr virus, that can invade the nervous system and grow within nerve cells, but don't necessarily cause any problem in the majority of people that we know of. So those three different definitions come into it when we talk about, does COVID infect the brain? Is it possible? Yes, certainly. We've seen cases where we found good evidence of COVID infection in the brain. Is it common? Almost certainly not. And is it relevant? Well, if we're saying, is it relevant to the vast numbers of people who've got neurological symptoms after COVID? I think the answer is no, not from the evidence I've seen. So yes, I do think it's possible, but no, I don't think it's common and relevant to the vast numbers of people. So I think that's an important thing to say as well, that yes, lots of things are possible and we can see them in scientific studies, but that doesn't mean that they're common and relevant. And especially when you've got a large denominator, billions of people worldwide infected with COVID, even if something is only happening in a very, very small minority, we're still going to see it. And of course, we tend to talk about things that are rare and unusual, and that creates a bit of a bias and makes those things reach the scientific and the popular press more. So mental health. Now we've got loads of really high quality evidence showing that there's a significant risk of mental health problems during and after COVID. There's a significant risk of depression and anxiety during infection, significant risk of psychosis, a disorder where there's problems with thought and emotion and losing touch with reality, and that risk is persistent for, again, up to a year at least. And the risk is there with other respiratory infections. It's there with influenza. We've known that for a long time, but it does seem to be greater with COVID. It's associated with hospitalization, i.e. people who had more severe infection, but it does seem to be present across all severities, including people who had very mild infection and stayed at home. And it's comparable between Omicron and Delta variants, we think, which is interesting because you think, well, Delta is more severe, so wouldn't that be more likely to cause these problems? But that doesn't seem to be the case. We do know that vaccination reduces that risk. In people who've had a vaccine, who then are unlucky enough to have a breakthrough COVID infection, the risk of mental health problems is reduced. But if you look at the data, I'm not going to go through the numbers here, but although there's a very significant increase in the risk, like this finding is robust, many studies have shown it, the absolute increase in risk is actually quite small. So what we're saying is that there definitely is effect, but is it affecting an enormous percentage of people? No, not necessarily, but many, many millions of people have been infected with COVID. So even a 0.15% increase in risk potentially could have a large effect. Sort of changing tack here, but just to say that what I've said here isn't new. This is William Osler, who was one of the preeminent physicians of the previous century, writing in 1892. just to give you an idea of how long 1892 was, that was obviously before COVID. It was before the influenza pandemic. It was even before viruses were discovered. But in 1892, before viruses were discovered, William Osler was saying about flu that mental health disorders are really common. Depression, psychosis are really common. They can occur during flu and they can follow on. And that it's really important to look after yourself after you have an infection, because it takes time, weeks or months, to get better. And that lots of sensible things like having a good diet, getting plenty of fresh air are really important for getting better and having a good rest. So I'm not pretending that 1892 was a golden age, because obviously there's lots of stuff he's saying that is outdated and offensive, but the observations are valid nonetheless. And William Osler was making these observations before brain scans, before blood tests, just from listening to people and hearing what symptoms they had and how they evolved. So mental health problems following infection have always been common. So that brings me to more general thought, which is that infections outside the brain can and do affect the brain. Communication between the body's immune system and the brain's immune system is normal. When we have an infection, we feel ill in the brain. We feel tired, we feel headachy, we don't want to eat. That's normal. That's called sickness behavior. Now, what we're seeing may be hijacking of normal physiological mechanisms, but the brain doesn't exist in a box separate from the rest of the body. The brain and the mind share that box. They don't exist separate from the body. I've put there, slightly cheekily, the crest of the Association of British Neurologists, whose motto is primum omnium cerebrum, the brain above all. I don't think that that's true. I don't think the brain is above all. I think the brain has control over every part of the body and receives feedback from every part of the body. But the brain isn't somehow unique and separate from the rest of the body. Sounds like an obvious thing to say, but something I think that's worth saying. So then going on to the more long-term complications, dementia, very important. So we know that markers of brain injury that we can detect in the blood are elevated when people have severe COVID infection, and that there is an increased risk of subsequently developing dementia for some years afterwards. And not just dementia, but cognitive decline that doesn't meet criteria for dementia. We know that the rate of cognitive decline is faster, and also the rate of brain shrinkage, atrophy, especially in the limbic system, which is this very ancient part of the brain that's linked to smell. So that gives the interesting idea that could it be that we know that anosmia, loss of sense of smell, is really common after COVID? Could it be that because that bit of the brain isn't getting used because it's been disconnected from smell, could that cause it to shrink? We know that happens in lots of other causes of dementia with hearing. That's why deafness is a really profound risk factor for dementia, and why it's really important for people to get their hearing fixed if they can, because when the temporal lobes are disconnected from hearing, that can cause them to shrink faster. Maybe the same thing's happening here with the limbic system being disconnected from smell sensation. Now that study about brain atrophy got a lot of press and showed a really significant finding in a large number of people, but it was subtle. It was very subtle. The rate of brain shrinkage that they showed was very small. So that's important to say. Now, conscious of time, so I'm going to move on to long COVID. Now, I've put this last, not because I think it's the least important. I think it's the most important. But I've put it last because I think it covers all of the things that we've spoken about before in terms of mechanism. It touches on all of those, because the mechanisms in long COVID are highly likely to be some part of all the mechanisms we've spoken about before: vascular, inflammation, mental health, neuronal loss, all of those things, right? And in combination with quite a complicated interaction with host susceptibility and the severity of the infection. And I haven't even spoken about how COVID affects the rest of the body, because that's important, right, to the brain. If COVID affects the lungs and causes a lung injury, which causes hypoxia, which means that you feel breathless, then that's going to affect brain function and make you feel anxious. Feeling breathless, is like having a panic attack. So we can't just look at the brain in isolation. That's one of the key messages that I'm trying to make here, that even though I'm speaking about COVID and the brain, I'm wrong to do so. I'm wrong to do so by only talking about the brain, because it's one part of the whole body. it's very fashionable to talk about diseases being multi-system. But I actually think that's a pointless thing to say. Think of a disease that isn't multi-system. As doctors, we look at organs and go, okay, well, how's this disease affecting this organ? But we're not just a combination of organs. We're one whole organism. And most diseases affect the whole organism. So I think that's the right way to look at long COVID in particular. And yes, it is a multi-system condition, but so is everything else. So the things to say about long COVID are that it's sadly very common. There are some risk factors that have been identified, but many people have no identifiable risk factors and are perfectly well beforehand. And the causes are likely to be multiple and overlapping, involving several of the things that we've spoken about before. So maybe all these things go on during and shortly after COVID infection. And maybe for some people, the endothelial injury is the main thing, and that causes a stroke. Maybe for some people, the immune dysregulation is a main thing, and autoimmunity, and that causes an inflammatory syndrome. And maybe for some people, lots of things are going on, but at a lower level, and that could be associated with this syndrome that we call long COVID. I'm going to wrap up now because of time. So there's a lot of research going on at the moment, especially into long COVID. COVID CNS we're involved in, that's headed by Liverpool. Studies in London and in Leicester, and Recover is a big US study. And quite right, because I think this is a very important issue and is going to continue to be an important issue. So here are my conclusions. There are other conclusions that would be perfectly valid to make. How could a pandemic of this scale not have effects on the brain? It's almost inconceivable. Of course, this pandemic was going to have effects on the brain. There are lots of parts to this story. I've emphasized biology, but I think that psychology and sociology are just as important. There's an interaction between the host and the trigger. Severity is not the only factor. We've all seen people who've had a relatively mild COVID infection who've gone on to have severe symptoms. My talk was headed COVID and the brain, but really, could I have given the same talk about any infection in the brain? Probably. And multi-system, yes, we need to think about how all the body systems interact together, but really, that's not unique to COVID. What isn't multi-system? All diseases are multi-system. We are not just a collection of organs, we're a whole organism. So my call that I've had personally and would highlight is that we need to improve our understanding of how the brain is involved in systemic infection, because systemic infection is common and brain problems during and afterwards are also common. We need to do that for all these people who've got troubling post-COVID symptoms, but we also need to do it for all the rest of us as well. So I'll say thanks to the MRC and the NIHR who fund me, and to the Coroner Studies Group, which Tamsin mentioned, which I'm part of and is looking into neurological complications of COVID. Thank you very much for your time.